Okay, let's say you're going to get a knee replacement. How much of the success of the surgery? This is a question. I'm posing this question to you.
Hypothetically?
Yeah, you're getting a knee replacement. How much of the success of the surgery comes down to your condition going into it?
Before the surgery.
Before the surgery, like how fit you are.
That's something I never would have even considered. But I mean, I guess because you're asking this, the answer is probably like quite a bit.
It is. Yeah, I mean, you're correct. Correct. Yes. 80%. Yeah, this episode is all about sports therapy and rehab. And in it, the two doctors who are talking about it, which I had no idea about this, said that 80% of the success or failure of your given hip replacement, knee replacement, anything like that, like any major kind of therapy, sports rehab therapy, comes down to your pre-surgical condition.
I don't think that's something people know. I think back to people I know who've had surgeries like this, and I don't think that's ever been on their radar.
And there's all sorts of stuff about sports therapy and rehab that people don't know. Like this field of medicine is flourishing, and it's flourishing because there are all these aging athletes who want to keep going longer and longer and longer than ever before. And you think about it, like you see people on bikes who are in their 60s and 70s. You would never have seen that before. You see people running. Well,
some of the guests on this show, we had Kiho Taivasalo, Charlie Evans. Like these guys are athletic marvels.
Yeah, which is amazing, and which we all like. That's basically the dream. Like I want to be playing tennis when I'm 100.
Yeah.
And there is an entire field of medicine, sports therapy and rehab, and actually like of kind of medical professional services that has evolved to meet the needs of those masters athletes. And we're going to be exploring the field today.
And separating the fact from the fiction too, right? Because there's a lot of stuff out there there's
a lot of stuff that's just waste of money, quackery, not evidence-based.
And
what works, what doesn't,
right?
What is like a legit investment for your time and money and what isn't. That's what we're going to be exploring today.
Okay, awesome.
I'm Chris Shulgin. I'm executive producer of Eat Move Think.
I'm Jasmine Ratch. I'm managing producer of Eat Move Think.
So this episode is about the present and future of sports therapy and rehab. So the rising recognition of the importance of prehab.
Platelet-rich plasma therapies or PRP therapy. Does it really work?
When to use cortisone. And when is it better to try hyaluronic acid or even, one day, stem cell therapies?
Our two guides on the topic today are Medcan's Chief Medical Officer, Dr. Peter Nord, and Dr. Sebastian Rodriguez-Elizalde, who is Medcan's Director of Orthopaedic Surgery.
At Medcan, Dr. Nord is accountable for all sports medicine, therapy, fitness, and rehabilitation. He also provides sport medicine services for clients and holds his sports medicine designation through the Canadian Academy of Sports Medicine. He co-founded the Institute of Sports Medicine and Human Performance and was the team physician for the Canadian National Gymnastics team for many years. He also chairs the Rehabilitative Care Alliance for the province of Ontario, which oversees all rehabilitation services in hospitals and in the community.
Dr. Rodriguez-Elizalde is an orthopedic trauma and adult hip and knee surgeon. He has his master's in health administration from the University of Toronto's Dalla Lana School of Public Health, and he specializes in rapid surgical recovery and minimally invasive techniques, including direct anterior hip replacements. He also treats pre-arthritic conditions and works toward enhancing the patient's surgical experience. Academically, he is actively involved in several multi-center randomized controlled trials, and he serves as a lecturer at the University of Toronto in the Department of Surgery.
Here's Dr. Peter Nord in conversation with Dr. Sebastian Rodriguez-Elizalde.
Hi, everyone. This is Dr. Peter Nord, Chief Medical Officer at Medcan. I'm here with Dr. Sebastian Rodriguez, Medcan's Director of Orthopaedic Surgery. Sebastian, how are you doing today?
I'm good. How are you doing, Peter?
Good. Before we get into discussing actual sports rehab therapies, let's be upfront that we're discussing sports rehab not only as docs, as MDs with expertise in the field, but we're getting old ourselves and kind of interested in the present and the future of sports rehab. We're always looking for ways to stay active as long as we possibly can. And my own personal experience, I was in my 40s, so I ran marathons and triathlons and a lot of impact sports on these knees. And I was mid-40s, was in the middle of a run, and suddenly I had this terrible knee pain. So hobbled home, iced the knee, gave it a bit of rest, tried to run a couple days later. Like, no way was I running. So settled down, was a good patient, ended up getting an MRI. Buddy of mine, colleague of yours, ended up saying, Peter, what did you do to your knee? It's like a yard sale in there. I said, nothing. Like, I just been running. I just ran. And he says, well, the running has taken a toll on that knee. So scope, clean out the knee, run a little bit more. About a year later, left knee, same thing. Just goes out, MRI, yard sale, scope. And it was at that point I had to say, well, what's the long term? Like, am I going to be running and try to run and then end up with knee replacements at 60? So I kind of made the adjustment. I said, look, I love all sorts of sports, and maybe running is just not going to be in my future. So one of the strategies to being active is you kind of you pivot, right? You do something a little bit different. And so, that was kind of a strategy. But since then, like, that's literally, now I'm 60. So that was like 15 years ago. And in the last 15 years, like, a lot of stuff has happened, and offered 15 years ago, maybe I'd be still running. But that was kind of my story. How about you? Have you had any, history personally with sports injuries?
Yeah, I mean, I've had a couple of shoulder surgeries. One when I was younger, I dislocated my shoulder a few times. So I had my shoulder stabilized, and not recently, I guess 4 or 5 years ago, I had it redone. I've had various knee injuries from contact sports from when I was younger. Nothing ever treated surgically, but I know there's a lot grumbling in my knees. So I try and avoid getting MRIs just because sometimes it's better not to peek under the covers, so to speak, and leave well enough alone. But yeah, I've had back surgery actually. A couple of years ago, I had a disc taken out. Yeah, and I think as you age, I think you've indicated, your ability to recoup naturally, it changes. When you have an injury, sleeping it off, when you're 20 or 25 and taking a week off can often be enough. And, I'm in my 40s now, and that's certainly not the case. Or if you do too much at the gym, or, you ski too many days in a row, you'll definitely feel it more. And certainly I hear that from my older patients. Every decade, there's a difference in the body's resilience to recover and how fast it takes to recover. And then, people like us are sort of here when it doesn't just recover on its own.
Right. Yeah, we get lots of questions about that, especially amongst our older athletes, the masters athletes. And up here in your head, you kind of go, yeah, I got it. And then your body's like, what the heck? The body's not following along, or it's a little easier to have overuse injuries. And like you said, it's a little slower to heal. That's one of the things I found. I'm probably as strong and probably as fit as I was in my 40s, but I just find I get overuse injuries way easier, and they're just slower to heal. So really frustrating. So like many people, kind of looking for that thing that's going to maybe accelerate the healing a little bit, get us back in the game. So let's talk about that. So the sort of a short history of sports therapy as a mechanism to optimize and prolong activity levels for our aging athletes. If we think back to what was happening back in like the 70s or the 80s when, long distance running was just sort of coming into its own, people really weren't doing a lot of intensive activity. They weren't doing a lot of contact sports or anything. And now when we scroll forward in these days, whether it's something like in the home gym or Peloton or yoga, Pilates or cycling or running or like pickup hockey. And even, I've got patients in the sports medicine clinic, they're in their 60s, they're doing contact sports. In fact, one of our docs here still does karate, and he's in his 60s. And, you take a little bit of a risk by doing that, but boy, are they staying active. And along with that goes some injuries that can happen. And so, what we thought we might talk about is a little bit of where we've evolved from and some of the cool things that we're doing now, and even maybe what the future holds for the whole rehab area. So let's talk about something that we get a lot of questions about. And one of those things that we hear a lot about is this platelet-rich plasma therapy, or more commonly known as PRP. We've had athletes like Tiger Woods who've kind of lined up behind the therapy. So what do you think of it? Does it work? And when do you use it in your practice, and to what end?
Yeah, so I think PRP has been in the mainstream media more and more, and there are a lot of clinics, including ours, which offer this as a therapy for people recovering from injury or management of some of their chronic diseases. PRP, was seen by some people 5, 10, 15 years ago as sort of fairy dust or pixie dust, and, not really scientifically vetted that well. But there are multiple now randomized controlled trials indicating its efficacy. So I don't think there's that much of a debate of, does this work? The question is, will it work for you? So a lot of these injection therapies, and PRP is sort of no different, is, are you a good candidate for it? Will it help you? How much of an effect will it have? and how often do you need to get it. So we have very good studies that show in mild to moderate knee osteoarthritis, PRP is a very well-validated tool to be able to use to help manage that condition. And I think I say the word manage because for a lot of these conditions, you're really managing it. You're not injecting something that's going to reverse the natural course of a degenerated knee. So if you have a knee which has osteoarthritis, that's delamination, fragmentation, and loss of articular or that smooth cartilage in the knee, there's nothing I can really put in there that's going to make it grow back like you were 20. So, to be perfectly clear, I think a lot of these therapies manage, and they can manage that knee pain and that knee sensation in a lot of ways. And part of that is by reducing the inflammatory nature of the knee, the bogginess you feel in that knee, the heaviness you feel in that knee, by sort of down-regulating the production of knee fluid or synovial fluid. The pain receptors in the knee get turned off. And so you get a return to a more natural milieu and a less inflamed and angry state of that knee with an injection like PRP. So the million-dollar question is, how long does that last? And for some people, that can be a series of 1 to 3 injections could last them several months. And for some people, it can be a year or 2. But I'm clear with my patients that this is a great way to help manage their disease. This is not necessarily a complete cure, but it could be something that while you're waiting or while you still want to run that one last marathon or still be active, and before you're really thinking about something surgical, you can use to help manage that disease state. By an extension of knee, we've also successfully used it in hip arthritis to also help manage a lot of the symptoms that people have with hip pain. And some of my foot and ankle colleagues use it as well in some degenerative states down there. So I think it does well for that. PRP is used in many other medical disciplines, as I'm sure you know, between dermatologists and hair regrowth people. There's a lot of people using it for different reasons. And it's because in that plasma that we take out of people, there's a lot of growth factors. And frankly, I don't think we understand exactly fully how a lot of them work. But, we've had a good 15 years of evidence that show us it does work.
Yeah, it seems like in different parts of the body too, the studies I saw good studies looking at ankle sprains even. If you need to get a professional athlete back in the game, it is going to speed up healing, get them back long term, not a big difference, but for that next couple of months, it means they can get back in the game, be competitive.
Absolutely.
Yeah.
And so I think of PRP in 2 different ways. One is for an arthritic state of a joint. So inside that joint where you have synovial fluid and you want to be able to treat that, I think PRP is great in terms of for that use. And so our machine here, which is an Angel machine, allows us to sort of select, what percentage of PRP we want, how many white cells, et cetera. And so you want to, to reduce the inflammatory state, you want like a 2% PRP in that. When we look at tendon injuries or chronic tendon injuries, golfer's elbow, tennis elbow, that kind of thing, chronic Achilles, you want a bit different PRP, something which does induce a little inflammation because inflammation means healing. So, in those types of states, you use a slightly different version of PRP, essentially the same thing, you're taking blood, but, how many white cells are in that, or a little bit more. And that sort of a little bit of inflammation sort of is painful, to be honest with you, when you inject it, but that helps to stimulate the body to help it regrow. So the sort of 2 different uses of PRP, but both of which come out with the same goal.
Yeah, some people may, if they're doing some research on this, they might see this LR-PRP, which is leukocyte-rich as well. So just for everybody, the leukocytes are the white blood cells. That's the white blood cells. And getting that balance between the white blood cells and the platelets, as you said, is really important.
Exactly. And, to be honest, many clinics here in Toronto and around the world, there are a lot of different ways to do PRP. At the end of the day, the patient sort of sees, a nurse taking their blood and gets an injection put somewhere, but where that blood goes and how much you're taking out, how much is then spun for how long, what's being taken out, what's left in, and then where it's injected and how is all variable. So, that's why I think a lot of the evidence initially scientifically was mixed with PRP because there's so many ways to deliver it that we're not rigorously controlled. And so now I think that we've tightened up some of those parameters. You can get good quality evidence and eliminate the noise.
Yeah, so studies are getting better now than they were initially just because there was so much variability in those early studies.
There was. And it was an inherent bias. You have people that think this is going to cure everything. And then you have people that are absolutely, well, this is not mainstream medicine and it cannot be useful. And so, it's quite polarized. And I think the reality, like most things in life, is somewhere down the middle and that it won't cure everything. But yes, it has a role in certain conditions if well applied and if the patient follows through with the rehab after.
Mm-hmm. And there's a bit of a cost to it as well. People need to know it's not covered by health plans yet. Maybe in the future, insurance companies will cover it. But, the price point can be anywhere, many hundreds to thousands of dollars.
Absolutely. I mean, PRP, it's not for the faint of heart. It definitely, it has a price tag. And right now, I think, Health Canada doesn't approve it and a lot of drug plans don't approve it. And it's not because there scientifically isn't a valid reason to do so. I think it can be just cost prohibitive for a lot of plans and people, but it doesn't mean it doesn't work.
Yeah. So how would you position PRP against cortisone and even hyaluronic acid injections? Maybe you can go into sort of when do you use one of those three? Because a lot of people may hear those three different
Absolutely.
things.
I think that's a great question. So I think those would be the three sort of standard injections we would offer someone with, let's say, early knee arthritis or degenerative changes. And I think for me, the ideal person who has a cortisone injection, there's two. There's someone that comes in with a very hot, suddenly painful knee that needs to be treated sort of like immediately. And to really reduce that inflammation, there's nothing better than a cortisone shot in the short term for that gain. So if they've had a sudden injury and are really bothered by that pain inflammation, they're a great candidate. I think also people that are over 80 that may not have great cells or platelets for PRP, I think cortisone serves a great role as well.
Mm-hmm.
Typically, those patients are maybe slightly less higher demand, and so they react well to a cortisone injection. Might be all they need. I think the cost point for a lot of those patients that I see in my typical hip practice, it's a lot easier to do for some of them, and it's more accessible as well.
Mm-hmm.
I think hyaluronic acid sort of falls in between. The benefits of hyaluronic acid is, like PRP, it's been well studied and definitely has a role in mild to moderate degenerative changes of affected joints. Again, like PRP, it's not really a cure, but can help manage that disease state much along the same veins as PRP, helps to reduce inflammation and turn off pain receptors. That patient for me is maybe doesn't necessarily want cortisone. They see themselves as much younger. So if you have a younger patient, you don't want to be doing repetitive cortisone shots in someone in their 30s or 40s with some issues, because the cortisone can have long-lasting effects if done repetitively to the surrounding tissue. So, if you're 80 and waiting for your knee replacement, cortisone might be all you need, and understanding that you're going to get a couple of those cortisone shots and then you're going to have surgery. But if you're 30 or 40, you're not really looking at a knee replacement. You want something to manage you long-term. A biologic solution like PRP is excellent, or hyaluronic acid might be something you'd consider. Hyaluronic acid has a bit of a more rapid onset of action than PRP. It often feels more definitively better earlier on. The studies show, though, that PRP can actually outlast hyaluronic acid when used and compared to head-to-head. So the magnitude of effect and the duration of effect in the latest studies actually favor PRP over hyaluronic acid. Both of those injections far exceed cortisone, which really peaks out after 6 weeks. So it's really a short-term thing to get you over something. The other reason we use cortisone, sometimes we combine it with a hyaluronic acid just to give you that short-term interim relief and then a longer-term sort of hyaluronic acid sort of buffer. So those two are used in combination, quite frequently here at Medcan as well.
Yeah, I often tell my patients, because a lot of questions about cortisone, that it's a bridge. You've kind of plateaued in your physio, you got some pain restrictions. Now is also a time that we can, get that, settle it down. It's like putting water on a fire. And that allows you now to get to that next level of physio that's actually going to do the long-term benefit. That cortisone is not a silver bullet, doesn't create that it's not a long-term solution. And like you said, repeated injections can be negative. You're actually down-regulating a lot of the natural processes. And I know back in the 60s, 70s, they were injecting Achilles tendons repeatedly and they just ripped. So generally speaking, we're not really injecting cortisone into any weight-bearing tendons or ligaments, just because the chances you can weaken those tendons and they can just tear.
Yeah, cortisone is typically not used in and around tendons, unless you have a tendinitis like at a low dose for something, but not exactly. Achilles and quadriceps and patellar tendons you don't want to do. There's a large paper that came out by one of my colleagues from Sunnybrook a couple of years ago about cortisone not being efficacious in knee arthritis. And I think, a lot of patients came in after that asking about I heard cortisone doesn't work. And I'm like, well, yes, you're correct. Cortisone will not cure your arthritis in the knee.
Mm-hmm.
cortisone is a means to manage this for a few months, until you get surgery or until you've lost some weight and done some physio, but it will not reverse the processes in your knee. Because you hear stories of people coming in, they've had 8 or 10 or 12 cortisone injections. And I think, once you've got beyond 2 or 3, it's not that cortisone stops working. It's just that you should be looking at different alternatives of how you're going to manage this patient. I think there's the exception for the elderly octogenarian or, who's, really doesn't want anything invasive done. And this is what's helping manage their pain. I understand that. But for someone your age, I think repetitive cortisone injections are not as good. And a biologic solution like PRP is probably better because you're not putting in a foreign substance and it's really from your body being used to heal your body, which is probably beneficial.
So what about stem cells? We're hearing little buzz around stem cell injections as well.
I think, and stem cells is a great topic. Stem cells is the PRP of like 15 years ago. It's sort of all encompassing. It's sort of, this black box. And unfortunately, like in Canada, there's been a moratorium on the delivery of stem cells, both from fat. So a lot of clinics were taking fat, aspirating fat, like a mini liposuction, spinning it down to get some stromal cells and injecting it into joints. And some people were using bone marrow, which we had even tried here at Medcan. And that was, your bone marrow essentially makes your blood cells. So it makes sense that if platelets are good for PRP, in my evaluation of it, when we looked at the science, taking bone marrow, which makes platelets, and getting a rich source of that would be even better. But right now, they've stopped that for a lot of clinics were sort of selling stem cells as this can cure everything. And I think, that's misleading to patients, because they come in thinking they're getting stem cells and it's in the news a lot. People are talking about it, but, there's not a good definition of what is a stem cell. There are multiple different types of stem cells. There's stem cells which create their own lineage in terms of regenerating cells, and there's stem cells which are pluripotent or can create a variety of different cells. And so, people have to understand where these cells are coming from, what they're capable of, and then finally, like where you're putting them. I mean, you can put stem cells literally anywhere via injection or infusion, but it doesn't mean it's actually going to treat that problem. So I think it's with guarded anticipation that we can look forward to medical advances in stem cells and their applications towards either chronic disease or in acute injuries. I don't think we're quite there yet. And, I was chatting earlier, I think really the role of stem cells in the future will be with genetic testing. We can say like, you know what, Peter, like you're not meant to run. Your knees are terrible. But if we talked to Peter 20 years ago, we'd say, hey, based on this genetic test, your knees are not good. But we can give you the stem cell injection, which can make, your predisposition to knee arthritis, we can reduce that by 80%. So it won't cure you, but it'll decrease the impact of that disease on you in the future. I see stem cells, the benefit in the future, being something like almost like a vaccine for something you don't have yet. I think at the end of the day, when people come to me and they're in severe arthritic state and their knees are deformed and varus, like the idea of just injecting a few cells to regenerate a knee like they're 20, is a bit far-fetched. Like you have a lot of forces going through a joint, which has aged over time. It's not just a few cells, but the nature of the bone density, the bone quality, the underlying bone that, is right underneath your cartilage, which supports that structure. The ligaments and tendons, which are involved with the muscles around that joint, have all been affected. They've all been thinned or chronically tightened and misshapen. And so just one simple injection might make you feel better, but it's not going to correct that underlying deformity.
That ship has sailed.
Yeah. So I think that I'm not saying stem cells don't have a use. I think they're going to be therapeutically very valuable. I just think they're going to be valuable maybe earlier on in the disease process for some people.
Yeah, and I think you've landed on and you would talk about the future. And, at Medcan, obviously, we've been very strongly supportive of our genetics program. And most recently, now we're doing whole genome sequencing. So looking at genetics and precision health, and you're lining up exactly with that as well. Like even in orthopedics, we can be looking at genetics, matching that with evidence-based best practice, and start to, in a very proactive way, rather than a lot of what we do is reactive. So be very proactive, get in front of a problem before it becomes a big thing, and then, manage that along the way. And who knows how much longer we could be running or performing our sports.
Absolutely. I think that'll go a long way because right now we have patients and, they ask the same questions you do. What's better for me, a hyaluronic acid injection or a PRP injection or cortisone? And as a physician, you have your own biases based on the criteria I told you, but some people just react better to one type of injection or another. And it'd be awesome if, through our genetics testing, we would be like, you know what, like you're really built for hyaluronic acid. You're not meant to have PRP or vice versa based on this profile, because identical people of the same age and same condition will get these injections and one will react much better than another to one of these injections. And you really don't know until you try. So I would emphasize if you've had an injection that didn't work, often trying a different type of injection could offer you relief. So it doesn't mean all injections are off the table. But, I think that having some guidance that way, which I truly believe is there's some genetics there that we just don't know about, will help guide treatment in the future.
Yeah, I think 20 years from now, we'll look back and go, gosh, it was just trial and error. Like so much of what we do in medicine is like, this antibiotic doesn't work. You know what? We'll try this one. Or if this antidepressant doesn't work, you know what? There's 20. I'll choose the next one. And they're going to look back and go, so where's the science in medicine if half of it is like trial and error? It's like, well, you know what? That's where the art comes in. You assess the whole patient, kind of see what you think is going to be the best choice given their milieu. And then more so than that is if we can start to lean into their genetics, start to proactively, again, pick stuff. We have a program that's very successful looking at medications. So we know that you have a much better chance of reacting to this medication versus the other medication based on your genetics. So that's definitely the future. There's no question that's something that we're excited about.
If it works for medications, it's intuitive that it would work for therapeutics in the future as well.
Yeah. And also, what I think some of the evolution about in sports rehab and sports medicine is just the fact that I think, I'm thinking back 20, 30 years ago, it was sort of a linear approach to rehab. You saw the doc and the doc kind of managed you. And then, maybe you saw, maybe it was a primary care doc and then he couldn't manage it. So you're off to the orthopedic surgeon. Maybe there was a specialty orthopedic surgeon, but it was pretty linear. And increasingly over the last, 10, 15, 20 years, that idea of that interconnected, interprofessional, comprehensive, holistic care has been shown with many studies to be way better than what we were doing before. So bringing in a chiropractor, bringing in physio, bringing in occupational therapy, all the pharmaceuticals that you can bring to bear. And, at Medcan, even we've got the benefit of offering nutritional assessment, fitness on top of that to really round out the whole team. So while it's not rocket science, it's not quite as sexy as PRP and that sort of thing, it's sort of evolved over the last 15 or 20 years that all of us working together and leaving, any turf battles in the parking lot. When you walk in, you're basically there for the patient all together. And that's, I think, part of the secret sauce of Medcan is we've got all these pieces. So when a patient comes in, we all wrap around that patient and we all do what we're trained to do, complementing each other as well.
No, I think that's important. A multidisciplinary approach is for sure more effective. And, there's certain things the therapist is going to do and spend more time on that I'm going to do, and vice versa. A therapist isn't maybe going to inject someone's knee. So I think, having a combination of people is important. I think ultimately having someone that's guiding that care or looking at the big picture is also good because, everyone might want to pull the patient in 8 different directions. You sort of still need someone sort of, I think, steering that ship with oversight. But I think it's definitely more valuable to have more hands in the pot as long as they're all rowing in the right direction.
Yeah, somebody actually quarterbacking it.
Exactly.
For sure. A couple other things that have been sort of timely and maybe some of the listeners have heard about it, quantitative MRI, which is interesting. So I think most people understand, an MRI is when we're looking in the knee, great at looking at soft tissues. Basically, the magnet is bouncing things that are fluid and non-fluid in the body. So that's one way to think about it, and the density of water and certain things. And this quantitative MRI is now looking at in the kind of the actual function of the cartilage and what's happening in the cartilage, what's happening in the bone underneath the cartilage, as you were mentioning, so that we can have a sense where, if you as a surgeon are looking inside and doing a scope and you can see that cartilage, well, rather than visualizing it, now we have some ways of looking through the cartilage and look at the physiology of like what's happening in that and the active metabolism that's going on in the cartilage and picking up soft spots or risky spots before they actually come to the surface too.
I think it's interesting technology. I mean, the question is still for like a lot of it is like, how does it correlate, right? Like, if your MRI shows that your knee is softening on the inside part of the medial side, there's very good ways to be able to look at that. The question is, what do we do with that now? Like, does that mean you do need an injection or you do need a scope? What if I don't have any pain there, but the MRI is telling me I should have pain? You know what I mean? So I think we're still trying to figure out how it fits in seamlessly, but it's very exciting technology.
Yeah. And from the surgery side, though, what about things like osteochondral transplants, actually taking either cadaver or a little piece of cartilage from another knee and putting it in there? Is that coming along now these days?
So that's been done, to be honest, probably for decades. I mean, the largest center probably in the world is at Mount Sinai Hospital here in Toronto, where they do that. So, fresh frozen cadaveric allograft from donors, essentially, in terms of meniscal transplants or cartilage, which has parts of the knee that, are attached to people if they have massive defects. So, that's been done. Dr. Alan Gross at Mount Sinai really pioneered a lot of this literally decades ago. The challenging aspect with that is that you need to have a donor. So you need to have someone that unfortunately, passes away. And the ideal person is it's unfortunately like a younger person that has good viable cartilage. And then you have to match sizes. So big football player versus little Asian lady is harder to put those two knees together. So, there has to be a degree of match. Those surgeries, when done well in select people, have had pretty good long-term success, but they're challenging surgeries. It's, you're replacing the inner half or the outer half of a knee. It involves plates and screws. Often we involve an osteotomy where we break the bone and realign it. And that's done to offload the new cartilage. So there's not too much pressure on it. So these are big surgeries that do take a long time for them to heal, both the osteotomy and the incorporation of the allograft. They've statistically got pretty good success at, at 5, 10, and even 15-year survivorship. But they're, to be honest, pretty limited in terms of people who do get those. So people who get that generally have a focal lesion of cartilage defect or loss. And that's not your typical arthritis patient. That's typically a younger patient or a soccer player or a basketball player who landed funny, has a well circumscribed 2 by 1 centimeter lesion somewhere in the femur that can be changed, or half their knee has been trashed in a motor vehicle accident, but the rest of it is still intact. So I would say those types of surgeries are more limited to certain population pockets of disease. The transfer of cartilage in the knee is done fairly routinely in terms of, saw a patient today from a non-weight bearing area, sort of on the lateral outside part of your knee, where you have good cartilage, and then taking a trephine or basically a circular piece of that cartilage and then transplanting it to an area that needs new cartilage. And again, that's been done for well over a decade with pretty good results. So you're taking out the bad pieces of cartilage, sort of making a nice round hole, and basically putting a cartilage plug from the same patient back into that. Again, the big question is like, how does that look in 6 months, let's say, and what are the tolerances physically of that cartilage? And a lot of published papers on good MRI results of that. How much does that, translate to, can this guy run again? Like return to sport scores, a bit more mixed. But those again are for very focal sort of areas.
Real specific cases.
Yeah, I mean, if you have generalized hip arthritis, I can't take a little piece because basically your entire hip joint, both the acetabulum, which is the cup, and the ball, your femoral head have to be changed. And people ask me, well, can you just replace the bits that are worn? And I say, absolutely. It's just called hip replacement. You know what I mean? Like, so you're taking out all the cartilage and you're putting in metal. Because, I mean, it's not just one little spot. So,
yeah.
I mean, I think they've tried that historically for many different joints, like plugs and little things. But the reality is for the majority of these arthritic conditions, it's the entire joint.
Yeah. And then, the other question I often get is about this thing called prehab. So, we've been talking about surgery and how do we get the best benefit from the surgery, whatever that surgery is. Maybe we can talk a little bit about what this prehab thing is.
Yeah, I think prehab is very important. And basically, it's flipping the script on rehabilitation. And traditionally, people came and they said, Peter, you wore out your knees. You need to have a knee replacement. Go get your surgery. And then it's going to be a hard 3 months of rehabilitation. And people did well with that, except it took 3, 4, 5 hard months of rehabilitation to bring back something which, for a lot of people, a chronic disease state has induced muscle loss, decreased flexibility, even decreased bone density because you're not using that joint that much. So the notion of prehabilitation is by taking that recovery period, which you need to have a successful outcome. It's partly the surgery and partially the health of the bone and health of the soft tissues around it, the muscles, the ligaments, and the tendons. And you can't get your surgery any sooner, but we can rehabilitate those tendons, ligaments, muscles, and even your bone density well ahead of your surgical date. And so essentially you're doing the same exercise you would do as a rehabilitative exercise, but you're introducing them much earlier. And so the notion of prehabilitation is, well, I can prepare for the test before writing the test and I'll do better on the test. And so the people that have done and put in the work that traditionally we looked at as doing after, which is harder to do because you're in a fresh surgical state, you're in pain, you're taking medications, anti-inflammatories, you have swelling and bleeding, and now you're introducing exercise. If you take that ahead of time and introduce it and slowly build the body back up to as best as you can do before your surgery, now you just have to recover from the surgery. You don't have to recover from a sort of chronic, debilitated state because you've done a lot of that hard work ahead of time. Multiple studies have shown that these people do much better. And really what we know now is that like 80% of your recovery is going to be dictated by, your prehabilitated state. So people say, well, John came in for his surgery and he did fantastic. Well, John happened to be in great shape and cycled 3 times a week and lifted weights and did yoga. And yeah, he needed this surgery to fix his shoulder, let's say, but he did really well after because he studied for the test. Whereas if you've never done anything and you spent the last year in pain and you haven't exercised and you lost a lot of mobility and you're stiff and weak, you're still going to be stiff and weak after surgery. It's just going to take you longer to get back to that state. So we cannot underestimate enough the power of prehabilitation. And I really think it mixes into the next topic a little bit, like in terms of fitness. People think of rehabilitation as I went to the physiotherapy and they put a magic wand on me for 30 minutes and I feel better. I did that 3 times a week. And the idea that physiotherapy isn't something that's done to you, it's something that you participate in to make yourself better. So it's really streamlining therapy to being something like regular exercise. So I think the physiotherapists value and the trainers that we have at Medcan and Andy Miners who help lead our sports rehab teams, I think it's that notion that, we're introducing exercise as a therapeutic, but this isn't something I'm doing to you. This is something I'm teaching for you to do for yourself for life. I liken it a lot to an oil change of a car. When you drive a new car off the lot, you have to still maintain it. And so whether you call it prehabilitation, whether you call it constant exercise, I think it's important. And I certainly think it's very important before any surgical procedure.
For sure. And probably more important even now. The health system, we're still coming out of a pandemic. The whole health system is backed up. We're way behind. It's going to take years to catch up. And so wait times are a real thing. So whereas before, if we could get somebody in 6 or 8 weeks or a couple of months, those days may be gone for a while. And so if it's going to take 9 months to get your elective surgery done, what are you going to do for that 9 months? Are you going to sit around? In which case you're going to get worse and worse. And the surgery result is going to be just that much more difficult to get a good result. So I kind of think even these days, it's even more important because wait times are just so long.
Absolutely. I think, there's 2 ways to approach the prehabilitation. One, it's going to allow you to do better after your surgery. And 2, the physiotherapy and exercise prescribed ahead of time help manage your disease state. Like, your knee will feel better if you bike a few times a week, if you do these stretches, if you build muscle mass. That chronic knee pain that you're complaining to me about will get better. Now, is it going to get completely better and completely reverse? No, but the benefit is that you'll enjoy life a lot better for those upcoming months if you're stronger and fitter and able to use your knee more often.
Yeah. And that also brings up one of the latest is VR. So my son, for his birthday, he wanted this virtual reality setup. And it's amazing some of the stuff that they can do through VR just to keep active and to keep variety. So you're not just like ride a bike for 30 minutes, every day, and that's going to be good for your knee, before surgery. But what other things can we be doing to keep people engaged? And so I started thinking back, remember back with the Wii, right? The Wii was like the biggest thing, 2006. Mm-hmm. And then, there's other apps and the sort of the gamification of rehab that's happened, especially as technology's gotten better. I kind of think back. So in a previous life, rather than sports medicine, I was working with stroke people. So individuals who suffered a stroke, and I was getting them rehabilitated. And a lot of what we were doing was exposing them to really basic apps, like on a laptop, nothing too fancy. But it really helped them to stay engaged, to really kind of focus and get their range of motion going. So whether it was from a stroke or sports medicine patients, it's one more way to stay active, keep variety. Because otherwise, if you don't have the variety in your prehab program, probably not going to do it.
Absolutely. And I think gamification of everything in life is important. And I think rehab and fitness is no different. I think that as humans, we love the dopamine and serotonin hit you get with like achievement. And so creating a list of things to achieve, creating pathways to be able to get that, be it levels in a game or lists, is important. I think Peloton, part of its success is that, I hate riding a bike. Like, riding a bike in the gym is abhorrent to me personally. Mm-hmm. But all of a sudden, you listen to music and you have numbers and you have comparables, like who's in my age group and what are they doing and where do I rank? What did I do last week? How many workouts did I do? So I think with anything, when people ask me, well, do I have to go to physiotherapy? Do I have to get a personal trainer? And I think when you have someone that writes down what you're doing and shows you the progress and shows you what you've achieved on a consistent level, I think it's hugely motivational. Now, some people are obviously very good at doing this without gamification, without apps, without tracking, without, a personal trainer. But I think those are all adjuncts which help tie in people into doing it. And you want to create a long-lasting relationship. And like I said, physiotherapy isn't something you're just going to do for 2 or 3 weeks and then it's done. It's sort of relearning your lifestyle to be able to manage your life fit for the next 5, 10, 15, 20 years or more. So you have to find something that you can consistently do and that, you're motivated to do and motivates you to do it.
Yeah, it's got to be fun.
It has to be fun.
Yep, or else we're not going to do it. So this has been great. I think just in terms of wrapping up, maybe some takeaway points for the listeners. We've talked a little bit about fitness. We didn't get in too much, but other episodes, we've talked about resistance versus endurance activities. That's going to be really important, both of those for prehab. We say, the studies will show 3 times a week is good. But what I've found over the years is folks that aim for 3, life gets in the way and that becomes 2 really easily. So I've often counseled people that in terms of that fitness, it needs to be a daily activity. You brush your teeth every day. You got to commit 45 minutes every single day, and then life will get in the way. And you might not get 7 in, but you'll get 4 or 5 in, as opposed to aiming for 3 and getting 1. So that's another takeaway that I usually recommend for the patients is really focus on that daily activity, focus on strength and endurance. We definitely want to maintain the muscle strength around the joints to support those joints, so that hopefully we don't have to see the surgeon.
I think that's what's changed a lot in the philosophies over the last 10, 15, 20 years is like previously, I don't think we had senior citizens that lifted weights. Lifting weights was something considered for 20 to 30-year-old males in a gym. And I think the overall outlook and approach to that, both from the gym and fitness scenario and from as physicians, has changed a lot. The benefits of resisted exercise are, I'm sure you've gone over these, are immeasurable. But for the senior population and those aging, I think it's imperative, especially in women, to do on a semi-regular basis. And it's not a lot of weight. It can be light, but it has to be more than just your body weight. And I think if you do that on a regular basis, as you said, 2 or 3 times a week as you age, immense benefits, because we do all lose muscle mass as we age. And the only way really to get it back is by doing resisted exercise.
So other episodes on Eat, Move, Think, we've talked a lot about that, so we won't get into too much, but I would encourage the listeners to really pick up some of those other episodes because all these things are connected. Like when you listen to all the different episodes, we have such amazing specialists and professors and people that are passionate about their area. It's amazing how all these things interconnect with each other and they support one another. We haven't even talked about nutrition, but nutrition, critically important for maintaining good health, keeping active, keeping those joints healthy. So there's a lot of things that all come together. So it's been great just to talk a little bit about sports med, where we've come from, where we're headed, how to, not have to have surgery, but if you have to have surgery, go for the prehab as much as we can. Just been great. Thanks so much, Sebastian. This has been awesome. Hoping we've been able to help our listeners understand that if they maintain the strength and fitness over time, they can continue to be active for decades longer than they actually may think. So with that, have a great day. And until next time, stay well.
Take care, Peter.
That was Medcan's Chief Medical Officer, Dr. Peter Nord, in conversation with Dr. Sebastian Rodriguez-Elizalde, Medcan's Director of Orthopaedic Surgery.
Medcan has a growing sports therapy and rehabilitation practice. We'll post on the Eat, Move, Think website a link to the webpage where you can arrange a consultation with Dr. Nord, Dr. Sebastian Rodriguez-Elizalde, and anyone else on the team.
Remember to rate and subscribe to Eat, Move, Think on your favorite podcast platform. Follow our host, Sean Francis, on Twitter and Instagram at Sean C. Francis, that's Sean with a U, and Medcan at Medcan Live Well.
We'll post episode highlights and links you can visit on our website, eatmovethinkpodcast.com.
Say hello and send us a tip or a suggestion by emailing us at info@eatmovethinkpodcast.com.
Eat Move Think is produced by Ghost Bureau. Senior producer is Russell Gregg. Jasmine Ratch is managing producer.
Social media and strategy support is from Chantel Gertin and Andrew Imex. Executive producer is Christopher Shulgin.
We'll be back soon with a new episode examining the latest in health and wellness.
This podcast is intended to provide general information about health and wellness only and is not designed or intended to constitute or be used as a substitute for medical advice, treatment, or diagnosis. You should always talk to your Medcan healthcare provider for individual medical advice, diagnosis, and treatment, including your specific health and wellness needs. This podcast is based on the information available at the time of preparation and is only accurate and current as of that date. Source information and recommendations are subject to change based on scientific evidence as it evolves over time. Medcan is not responsible for future changes or updates to the information and recommendations and assumes no obligation to update based on future developments. Reference to or mention of specific treatments or therapies does not constitute or imply a recommendation or endorsement. The links provided within the associated document are to assist the reader with the specific information highlighted. Any third-party links are not endorsed by Medcan.